Coming up today, it's the news every cancer patient wants to hear, to be told you're cancer-free. But 7 years later, Cynthia Newsome's cancer was back. We catch up with the Kansas City news anchor and learn more about her cancer treatment that wasn't even an option when she was first diagnosed. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Not every woman wants to share her story of breast cancer, but of course, Cynthia Newsome is not every woman. 8 rounds of chemo, surgery, and 33 radiation treatments. And after all that, Cynthia's cancer still came back. But we caught up with Cynthia a year ago, and today we get to find out how she's doing in this episode of Where Are They Now?
So what is so precious about this is that someone took the time to actually make this drawing.
You know her voice.
And they did a pretty good job.
That's you.
And you know her face.
In a month-long project we're calling Newsome's House Calls.
Kansas City news anchor Cynthia Newsome has been behind the KSHB news desk for the past 25 years.
41 News this weekend.
And I'm Cynthia Gunn.
For years, she's told stories from in and around her community.
Nothing like a little kickboxing for a heart-healthy change of heart.
But it's her own story she shares with us today.
And so I was doing a self-exam in the shower, and I felt the tumor. And I didn't know it was a tumor at that time, but I thought, okay, let's get in. Let's see what this is. Let's find out.
Cynthia was diagnosed with triple-negative breast cancer in 2011. It's one of the rarest and aggressive breast cancers, affecting Black women 2.7 times more than white women.
I'm stepping into my new role as breast cancer survivor.
Chemo and immunotherapy made Cynthia's cancer disappear for a time.
There's always a chance that cancer of any kind may return. So my husband and I talked about that once I had finished treatment, and I said, honey, what if? And he said, whatever happens, I'm here.
In 2019, the what if became a reality.
Hello.
Cynthia's cancer was back.
What's the latest on the scans?
It had metastasized and spread.
And I just believe that every day I have on this earth there's a purpose, there's a reason, and I want to have every day that I'm supposed to have and really deliver on that purpose. And that's why I tell people about my breast cancer.
Her philosophy, never stop living while you're still living.
What do you guys think about that?
And working is still a big part of Cynthia's life.
Putting it on your social media and your calendars.
She recently left the news desk and shifted to a new role at her news station.
To get the others excited.
Cynthia's story is also being part of the solution.
It's amazing because some of the drugs that I'm taking now were not even available when I had breast cancer in 2011. Keep up, babe.
At the advice of her doctor at the University of Kansas Cancer Center,
I think you can move that pillow.
Cynthia entered into a new breast cancer trial.
I think it's exciting. I chose to be in a clinical trial because it could help me with my breast cancer, but I do think about, gosh, will this help someone else later in the future?
This battle is really not all about us. What can we do? Number one, get her well and heal, but how can we allow this time to be of help to somebody else? There's nothing that I won't do to help her feel better.
As for the present,
do what you can with what you have. Enjoy your life and celebrate those around you, love those around you, because that's what it comes down to. The people who love you and the people you love.
And we are so excited to have Cynthia with us today. How are you?
I'm doing great. Thank you for having me. This is wonderful.
Thank you for coming in the studio. My dream to sit right next to you at the news desk. Only you're here at our news desk.
Here we are,
It's
yes.
so exciting. We also have your breast cancer oncologist, Dr. Priyanka Sharma. Dr. Sharma is an internationally recognized expert in triple-negative breast cancer. So Dr. Sharma, we'll get with you in just a moment. I have to say, Cynthia, I think everyone in our studio has worked with you in some capacity over the last couple of decades. I remember you when I was interning at KSHB, and you were Cynthia Gunn.
Yeah.
For those who've been around Kansas City a long time, you remember Cynthia Gunn, and now she is the Cynthia Newsome. So it's just really thrilling to have you with us. We're checking back in with you from a year ago. You're here with us on Pink Week. You know how important this month is. Just tell us, what you've been up to, and of course, how you're feeling.
Oh gosh, I feel great. There are good days and bad days, but generally I'm up and moving. If I'm having a bad time, it's just kind of a reaction a little bit, maybe from being tired or maybe the drug side effect. But it's nothing that keeps me down.
You've said before, like, bad days aren't really bad days. They're days that you still have, right?
Yes, they are. Yeah, and I love that I'm able to still continue to work. I'm still full-time at KSHB 41, Community Relationships Director, which I love, helping community and doing amazing things, to really inspire people, encourage people, and help people.
You're exactly where you're supposed to be. So you met Dr. Sharma before becoming a patient because you interviewed her for a news story.
I did.
Because you covered health stories through your career.
It was about triple-negative breast cancer.
Isn't that amazing?
And she was doing the research on it. And isn't it amazing? Wow, full circle all those years later, and now she's my oncologist.
Yeah, what was that like, though? Like having that full circle moment and knowing that you wanted to reach out to her when this happened to you?
It's an immediate trust because when you're interviewing somebody, you look at them, interview with them, you see them doing their research, you look at their data, you hear their passion, and that's before they're ever your physician. And so you already know the sincere hope and dedication and commitment to the cause that she has. And so, wow, yeah, I want to be your patient.
Well, and you go and you're asking these questions because you're trying to learn about a subject that you don't know in the future you're going to know a whole lot more about, even though you didn't want to. Dr. Sharma, just for everyone listening, explain what triple-negative breast cancer is and its current treatment options, as we know they'll change over time.
So triple-negative breast cancer affects about 15% of all breast cancers, and it's unique because it's defined by what it is not. Typically, we define hormone-positive breast cancer by hormones that feed the cancer. We define HER2-positive breast cancer by the HER2 protein that feeds the breast cancer. And breast cancers that don't have the two hormones or the HER2 protein get lumped into this group of triple-negative breast cancer. It tends to grow faster, spread more, and is more aggressive, tends to affect Black women disproportionately at a higher rate than other groups, tends to impact younger women at a higher rate than older women. And our current treatment options for this cancer includes mainly a combination of chemotherapy. And in the last few years, we've had immunotherapy drugs that have been added to this regimen. So typically it is some sort of IV type of treatment as opposed to oral treatments that we have available for other types of breast cancers.
So Cynthia, you and Ed get the news that the cancer came back, something you were not expecting. It was metastatic, meaning it had spread. How did you know it came back? Was it a feeling you had, symptoms? Was it part of your regular monitoring?
So initially, when I first had breast cancer, I felt the lump, and again, I felt something, right? It's near the sternum, really, that I felt something. So it wasn't quite on the breast. It was actually a little closer to the sternum, the center of the chest. And so, well, obviously, I'm not wasting any time, so make an appointment, get in, see what it is, and it turned out to be metastatic breast cancer, meaning it has spread. And so people ask me all the time, so how you doing? They think I'm great and it's fine and it's over and it's, I'm good, but it's continual treatment. And I guess I wanted Dr. Sharma to kind of explain a little bit about that this isn't something where I will ever stop having treatment, or help me, Dr. Sharma.
Dr. Sharma, jump in there.
Yes, so as Cynthia correctly said, metastatic breast cancer means that metastatic cancer of any type means that it is beyond the organ that it started in. So as she mentioned, for her, it was close to the sternum, so it had kind of gone outside the breast. And typically, when breast cancer goes outside the breast and is in other organs, one has to be on some form of treatment on a more or less continuous basis to ensure that the cancer stays under control. Those treatments vary by the type of cancer it is. As I said, for some cancers, we're fortunate to have oral drugs available that patients can be on as a maintenance therapy. For triple-negative breast cancer, it's mainly some form of IV therapy. Now that we have immunotherapy often we can do certain number of rounds of chemotherapy and back off the chemotherapy and stay on immunotherapy, which is less toxic as compared to chemotherapy. And then, of course, there are clinical trials that are looking at newer ways to treat this type of cancer, newer ways to do maintenance therapy without toxic IV therapy.
So, Dr. Sharma, Cynthia was on one trial, and now she's on another currently. I think when we talked to you a year ago, you were starting it, you were into that trial. What is the goal of that trial? What is it trying to find, Dr. Sharma?
So this trial is testing a combination of a class of drug called antibody-drug conjugate. And this is something that what we call smart chemotherapy. This is chemotherapy that's attached to a protein that can directly attach to the cancer cell and cause targeted cancer killing, and have less side effects. So that's why we call it smart chemotherapy. And this smart chemotherapy called sacituzumab is being combined with a targeted drug called alpelisib. This targeted drug addresses a pathway in the cancer cell that promotes the cancer cell to grow and expand. And this trial has been ongoing for a couple of years. Cynthia started the trial more than a year ago. And this is a combination of an oral drug and an IV drug. And we sequence these two to get the best approach for cancer control. The goal of this study is to determine the most effective combination of these two drugs. And then we would need to perform a larger study to understand the effectiveness of this combination on cancer at different stages.
So, Cynthia, such a push right now to get all ethnicities involved in clinical trials. It is so important to finding those cures and those treatments for everyone. You took part in these trials. I just kind of want you to be that voice and face today to talk to people about what that experience was like for you.
So being part of a clinical trial, first, Dr. Sharma, how can I say enough about her team, her feeling the trust and confidence? But honestly, she explains what is going on in a way that I can understand it. She answers all questions. There's no, question that's off limits. And so there's a comfort that you get, even though you're on a clinical trial, and this is a drug never been tried before. We're going to try it on you. Hope it works. Here we go. No, it's a very personal process where they explain what's going on. And so I felt comfortable doing it, and I'm excited, honestly. It's really an excitement. It's a joy.
And the stigma has changed when it comes to clinical trials. It used to be something where people are like, I don't want to be part of an experiment. I want something that's tried and true. I want everybody else to go through it. But you've called it exciting because you're able to really change the future of women and men who get breast cancer down the road, right?
It is exciting to think about that I had a hand in helping someone else, because I think about those people that were in the clinical trials for the drugs that I used when I first had breast cancer, and I'm grateful to them. I appreciate what they did, and so now for me to be able to full circle make that happen, I'm excited about it, and I'm really excited that the University of Kansas Hospital and Medical Center has been part of allowing me to help spread that word to people.
And you're advocating. What are you hearing out in the community? You've really kind of turned this into this mission. What's that been like for you?
So the mission is, first of all, we have to have people understand, don't fear breast cancer or any other cancer. We need to get in, get screened, get diagnosed. Yes, we don't want to hear the words, you have cancer, but you don't want to hear them too late. And I just breathe a sigh of relief, because I feel like, my goodness, how long has this been going on? I'm still, productive and moving and working and, enjoying family and life and, my faith and my nonprofit and all of those things. And I think about, wow, if I had waited, what might the outcome have been? So let's not wait. Let's first of all go ahead and get your screenings. And then if something is found, don't be afraid. Don't be afraid, but get empowered, get with a physician that you trust, and move forward with the treatment. And if you need to modify that or change, and in all this time, yes, we've modified, we've changed. The clinical trial was really strong for me at first, and I think we kind of backed down a little bit on the on the strength of it. And now I'm, able to thrive and, have a productive life.
Quite the mission.
Yeah.
I want to touch back on something really important with breast cancer and most other issues. There's always health issues. There's a health disparity. Death rates, as we mentioned, are higher, 40% higher among Black women. That's according to the Breast Cancer Research Foundation. And Dr. Sharma, I want to ask you first, just what can be done to help close that mortality gap, in your opinion?
So I think, as Cynthia mentioned, number one is encourage all groups to have screening at similar rates so we can identify cancers at earlier stages, more curable stages. And the second is access to health care and access to good quality cancer care, and that definitely has an impact in outcome, access to good surgery, good chemotherapy, good medical oncology has an impact. And I do think that the scientific community is starting to understand that in spite of these things, there are also biological differences in cancers that occur in Black women compared to Caucasian women. So a deeper understanding of that aspect will also be tremendously important in us being able to have more tailored treatments. And as Cynthia is doing, encourage all patients to consider participation in clinical trials because we need equity there. We need representation from all groups when we test new combinations, new regimens, and ultimately that when they get approved and are available to us to use in clinic, if certain groups are very underrepresented in those clinical trials, we don't have a good understanding of how effective those drugs might be against cancer in those groups. And we also sometimes don't have good understanding of what the side effects might be, because the side effects also might differ in certain groups. So it's important from all aspects. And all of this starts with, as Cynthia said, trust and trust in your doctor, in the team, in the institution where you're at. And clinical trials have changed quite a bit. It isn't always its first ever drug, never been tested. Often the trials at this stage are testing drugs that we know these drugs and we know the side effects, but we're testing novel ways to give these or novel combinations because often you need more than one approach to get to an aggressive cancer cell like triple negative breast cancer, and we're looking at combining more than one agent here.
So Cynthia, from an advocate standpoint, from that aspect, how do we hit this disparity head on?
Oh, so it's about the woman herself and having the confidence and strength and courage and knowledge to get tested, to get screened, to get help and treatment and care. But honestly, I'm thinking about, the children and the men and the friends who are listening right now. Take a moment, 10 people, that's all I'm saying, 10 people, this is a whole month. You have 10 people you're going to call this month, October, and you're going to say, 10 women, and you're going to say, hey, just checking in with you. I love you. Have you been screened? Have you had your mammogram? Have you done your breast self-exams? Because I found mine through breast self-exams, which was not the mammogram month, right? You do it once a year. It was November for me. That's my birthday month. But no, I found these, on my own several months later. And so it's so important, the breast self-exams as well.
So you've received many awards, the Block's Cancer Survivor Award, the Komen Kansas City Legacy Award, among others. Do you think of yourself as this inspiration, the way that the rest of us see it? I know that's kind of a uncomfortable way of calling yourself an inspiration, but we see it that way. Do you understand your impact? I
want to have that impact. So that makes me happy. Yeah. Those are some of the awards that I'm so proud of, because it means that people recognized that I'm having an impact and that I'm trying to make a difference and that I'm spreading the message that people need to save their lives. And that's the joy. That's the joy, is being able to help save lives. So I love it when people feel comfortable enough to just call me. You can just call me. You can just email me. I've had people call me and email me. My sister has been, diagnosed, or I've just been diagnosed, or I don't know what this is, or I'm a little scared, or and I can just be that voice. Personal thing. Yeah. And then of course, if anybody invites me anywhere, I try to go and speak on behalf of this subject, because it's so beautiful and so important to know that you're not alone.
Right. And it's such an incredible it's very personal, this
It is,
journey, and
yeah.
then you choose to make it very public because of your public persona. Why? Why was it so important that you said, you know, I'm not going to keep this to myself. I'm going to share it with others.
Yeah. So, my goodness, for all these years that I've been, you know, a news reporter, you know, my goodness, now 40 plus years, radio and television, people have shared their stories with me. It's been incredible to hear what personal things they have put on the air because they want to warn somebody. They want to tell them, look, it happened to me, it can happen to you. Let's forget being, you know, trying to put a face on it and front like it's not a big deal, but let's be honest. Let's tell the truth. Let's say it like it is. Be honest, and let's make a difference in this world and help some people before it's too late.
But you've had this huge amount of support, like an entire community, an entire city, you know, behind you, and that is so amazing.
It is.
But think of the women who just don't have the support that they need. What advice do you have for them? What kind of resources are out there for them?
So I think about, you know, maybe you don't realize the support that you have. But it has to start in the hospital when you're getting diagnosed. If you let them know, you know, if I told Dr. Sharma and the team, you know, I don't feel supported, I don't know who I can turn to for help, I need a ride to treatment. There are people who are alone in this world in the sense of no one to give them a ride. They're, you know, they live alone. And they don't, you know, they don't have the financial support that they need. And so to me, it's got to start with the team, the caregiving team. And they can then begin to connect you with those resources. And that's, you know, that's where I would start. But then don't forget that you do have neighbors, you know, that you might not consider going and asking a question to.
Yeah. Is it okay to reach out?
Absolutely. Okay. Absolutely. Or an old friend, someone you know that you knew at one time that you can trust.
Because people want to be there for you, but they don't always know how.
They don't know how, they don't know when, they don't know what's going on. And so if you don't tell people what's happening to you, then how can they, you know, respond and help? But if you do tell them, you know, they'll respond and help. And I just encourage everybody, don't wait for somebody to say, help, I'm diagnosed, I don't know what to do, I'm alone, I need a ride, I need some food, can somebody go to the grocery, can you please sweep the kitchen? I had a friend come over and sweep my kitchen. And I was like, oh, no. And then I was like, oh, thank God.
Oh, yes, please do. No,
you know, it was
I
like
say no, but I mean yes.
Right, I couldn't do it. And so you find something that needs to be done and you do it, and that's an act of love. It's sweeping the kitchen, but it's saying, I love you and I'm here, so I'm doing the kitchen, so let me know.
And you've said
I'm here for anything bigger.
Exactly. And you've said before to the supporters wondering what they can do, don't ask, just do it.
Just do it.
Don't ask.
Yeah.
So be sure to ask your questions to Dr. Sharma or Cynthia. You can use the chat on YouTube or Facebook. You can tweet us or email the Medical News Network. Info is right there on your screen. Let's check in with Dr. Dana Hawkinson this morning. Good morning. How are you?
Hi. Good. Hi. It's a nice day out. So right now we still have 22 active patients in the health system. Again, just the weekly numbers. It has creeped up a little bit the last few weeks. Hopefully there will be a plateau and we won't see any more significant rise over the next few weeks, but we just kind of have to keep our eye on it. And we know that we are still waiting for the major COVID-19 updated vaccine rollout. We know there have been some stumbles, but hopefully that will happen soon, and that will help reduce those risks of those people who are especially at risk of hospitalization. Once they get it, reduce their risk of coming to the hospital.
So, Hawk, a local high schooler is being treated for TB. They're a student at Olathe at Northwest. The Johnson County Department of Health and Environment is sending more information to parents and staff and students at the school. But just kind of help us understand, what is TB? How does it spread? What's the treatment?
Yeah, so TB is maybe more of the classical, like measles, the classical airborne spread, but it is difficult to get. You have to be in a room with somebody who is actively spreading the bacteria through coughing or things of that nature, because it is mostly a lung infection. Although other sites of the body can be infected, it is really those people with active lung infection who can spread the disease. And again, it does take a while. You have to be in a room with somebody for a long time. So although it is airborne spread, it is a little bit more difficult to catch than, say, something like SARS-CoV-2 or measles. As far as treatment, treatment is typically 6 months to 12 months, depending on the level of disease that you have. And it is typically with 4 drugs and then going down to 2-drug therapy if there is not significant resistance of that bacteria. So it is a very long time course for this as well.
So we're talking about one person diagnosed right now. What does that mean for the community overall? Anything they need to know?
Well, I think that means that we really need to continue to support our public health resources, our public health infrastructure, because this is one of the reasons, one of the many reasons why public health infrastructure and resources is so vitally important to keep the public safe. So what is going to happen now is testing of contacts, testing to people that have been around that person with active disease, and then following up on those tests. Monitoring them, looking for disease either by symptoms or by doing like chest x-ray. If there does seem to be exposure, there is the possibility of getting medication for that as well. And that will help reduce the risk at some point in the future that you do get active tuberculosis as well. So I think this really points to, again, our public health infrastructure, our public health workers who are out there doing that on the front lines every day to keep all of us safe really in the community.
All right, any reporters with us today? Let's get to a few community questions. And Dr. Sharma, Lisa wants to know how common it is to have cancer come back years later.
So breast cancer can come back even after initial treatment, and it depends on the type of breast cancer that initially was present. For hormone-positive breast cancer, it can come back 5, 10, 15 years later, and in about 15 to 20% of cases, it does come back. For triple-negative breast cancer, typically, if it will come back, it will do so in the first 5 years, and about 20 to 25% of in women, even after initial treatment, it does come back in other organs. As we have better treatments for early-stage disease, those numbers are improving. As we look at each decade of treatment, starting from 1980s, these numbers have continued to improve, and we hope that they do so in the coming decades as well.
Also, Dr. Sharma, is there any updated treatment approach for triple-negative breast cancer in the U.S.? Or what's the future?
So addition of immunotherapy to chemotherapy is the newest thing for triple-negative breast cancer. And with that approach now, there are many studies that are looking at optimization of treatment. So not take all drugs and all approaches and give to every patient, but think of ways to do just the right approach for an individual patient. Can we do less chemotherapy when we're doing immunotherapy? Can we do chemotherapy drugs that have less long-term side effects in combination with immunotherapy? Can we get by without immunotherapy in certain subgroups that don't need these drugs? And then the new class of drug, the antibody drug conjugates that are being tested in both early stage and metastatic triple-negative breast cancer show tremendous promise. There are many drugs that are being tested. There are a couple that are approved and available in clinic, and then there are others that are being tested in clinical trials. And targeted drugs also.
And just last question, any advice that Dr. Sharma can offer to triple-negative breast cancer survivors who are watchfully waiting for any signs of recurrence?
So as I said, you could look at the numbers in two ways. We can look at the number of 20% that it'll come back. On the flip side, in 80% of cases after treatment of early stage disease, there is cure. So I often tell my patients to focus on that 80% number and to live their life, to be with their family, do things that they enjoy, and let your physicians and your doctor and your team worry about monitoring you. You're being seen every 3 to 4 months. You're being closely monitored. Pay attention to things that are unusual and that last longer than 2 to 3 weeks. Normal things like colds, coughs, and other stuff will still happen. But if something comes on and lingers for 3 to 4 weeks and is just staying with you, call your team and let them know so they can evaluate you.
Cynthia, anything to add to that?
Oh, gosh. Don't worry about it, but just be mindful. Do your routine exams once a month, but don't let it distract you from living and life. I mean, Dr. Sharma said it as well. Live your life. be mindful of your body. If something happens, get it checked, but don't worry about it. I didn't worry about it for those 7 years, but believe me, when I was doing my self-exam and felt something, then we go into...
You got to get back to work.
You go back into work and get connected with your, caregiver.
All right, Dr. Sharma, what's the takeaway from today's conversation? What do you want folks to know?
Advocate for yourself and consider clinical trials, especially for women with metastatic breast cancer. Look into all options, including clinical trials like Cynthia did. And even though the metastatic breast cancer is there, you have cancer. The cancer doesn't have you. So live your life. Enjoy the time you have, spend time with family, work with your team to make changes in your treatment plan so you can do the things that you want. All of the things that we suggest are recommendations. We can tweak them, we can change them to help you do the things that you want and you enjoy.
Cynthia, so many great takeaways from your story. What's the one thing somebody hearing from you today, what's the one thing you really want them to take away?
I want them to take away, don't forget to call someone. You've got 10 people you need to call this month. That's really what I want them to do, because I want you to encourage people to do their self-exams, to get their mammogram, the 3D image of your breast, so you can get a baseline, and you'll know as the years go on what changes are happening. So it's just a very clinical medical thing, but it's also a friendship thing, and it's a love thing, where we're going to reach out to those people we know, women, and say, I love you. I want you to make sure that you've gotten your mammogram, you do your self-exams once a month, and thank you for doing that for me. So. Well,
we love ending the show on a call for action.
Yeah.
So just get out there and do what Cynthia does. Be like Cynthia. We appreciate you so much. And I'm writing you down. You'll be here next year. Same time, same place.
Let's do it again.
Let's meet up.
Okay,
we're doing it. Thanks to all of our guests, and thanks to our viewers for being with us today. We'll see you back here tomorrow. There's a new tool in the battle against breast cancer. I'm Jessica Lovell. On the next Open Mics with Dr. Stites, we'll show you the science of proton therapy, find out who makes a good candidate for this targeted radiation, and who benefits more from traditional therapy, according to research. Wednesday at 8.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.